I have an audio you can send to the class.
I have a post-it that says start recording and I still ignored it. That's something, huh? All right, so we're back to the heart this week. We're going to talk about cardiac, not anomalies, dysfunction, and when we are looking at the heart, and again, when we're back at the heart, we're talking about the ABCs. We're back up there in really the triumvirate of priorities, and like many things, some of the signs and symptoms and what brings the patient in can be subjective, and patients can use different words to describe it. So asking open-ended questions and really getting a sense of what's going on from the patient perspective is really important. So again, just starting with what brings you in, why did you come in today? What can we do for you? And as they start to tell their story, listen to the words they're using. When they talk about, and again, I'm not sure patients necessarily use the word fatigue all that often, but they certainly may speak to being tired, or they don't have the energy they've had in the past, or they get tired easily nowadays. If they talk about weight gain, if they talk about edema, swollen feet, things like that. Again, don't know that patients use the word edema all that often, but they may certainly talk about how when they get home, if they take their shoes off and there's no way they could get them back on again, or their socks are leaving marks in the top of their legs. Just stories like that. Shortness of breath, obviously, can't catch their breath, a dry cough. And then there's the famous indigestion, oh, it's just some heartburn. But they got their hand there and they're rubbing their sternum in the middle of their chest, sort of thing. Sometimes they'll talk about pain. Sometimes they talk about pressure. Sometimes they talk about burning. Don't discount jaw pain in the back, certainly their arms. And last spring, we talked about how women present quite differently than men. Women are almost always talking about fatigue when it comes to cardiac dysfunction. That tends to be their leading characteristic or symptom, if you will. Whenever we're talking about discomfort, you're going to have to go right into your old carts or PQRST, whatever it is that you do to assess the quality and perspective of that discomfort. Try to zero in on the locations. And in cardiac world, it may be in more than one paces. It may radiate somewhere. So make sure you get that perspective. What is the quality of the pain? Pressure, sharp, burning. Again, that's differentiating information. That's important. We revert back to our 0 to 10 scale. I have 1 to 10 here, but it really should be 0 to 10. Especially if we're looking to relieve that discomfort. What brought it on? What makes it worse? What makes it better? Especially when we're dealing with chest discomfort, we always say, what happens when you take a deep breath? What happens when you move? If we've got pain that gets worse when they take a deep breath, I'm not saying it's necessarily good news, because that could be indicative of some other bad things, but pain that gets worse when you take a deep breath often is not cardiac based. It could be costochondritis, more muscular, or it could be a respiratory issue. And while a pulmonary embolism may not necessarily be good news, it might be better news than myocardial infarction. How long does it last? And again, what makes it better? What makes it worse? Those sorts of information as well. And then there are the other signs and symptoms, nausea, dizziness, um, anxiety, palpitations, a lump in their throat, things like that. And denial is a beautiful thing. People can deny something's happening, or especially when it's a nice burning pain in the center of their chest, they will swear that's heartburn even after, you've done CPR on them and stuff like that. So their ability to deny and discount should not necessarily dissuade you from what you know to be a possibility. And the other thing I found with cardiac patients, and this goes back to the anxiety thing, when they tell you they're very nervous and they're really afraid and they think something bad's going to happen, believe them. Again, that's one of those times where and I don't say it's going to be okay or you're here now. I might say, well, I'm glad you're here. We're going to do our best to take care of you and stuff. But when they're talking about something bad's going to happen, believe them. Don't you go into denial also. And again, that's that gut. That's listening to the little voices in your head. That's just not easily quantifiable, but will certainly screw your rest of your day. Family history is important. We know that there are lots of cardiac problems that are genetically related. So understanding what's happened to their parents and siblings is important. And then again, we've also studied the many risk factors for cardiac dysfunction: smoking, obesity, hyperlipidemia, hypertension, stress, diabetes, metabolic syndrome. All of these health issues fall into the risk factor categories. What medications are they on? And I'm not sure it happens as frequently as it used to, but you have people come in with all their pills in a plastic bag. And I'm not talking pill bottles in a plastic bag. I'm talking the pills they scooped out of the candy dish, like my crazy Aunt Dolly used to keep them. And they'll tell you, oh no, I don't have any heart problems. But you start looking at these pills, and when you see the metoprolol and the lisinopril, gives you a sense that somebody thought they had some heart problems, and you have to do some deeper diving there. And again, so just to define metabolic syndrome, 3 or more of the following risk factors: a large waistline, either being treated for having high triglycerides, being treated for having a low high density lipids, hypertension, or high fasting blood sugars, or a pro-inflammatory state. And in terms of pro-inflammatory state, that's whether that's measured by C-reactive protein. Sometimes a SED rate can be substituted for that as well. But we know metabolic syndrome is a significant risk for cardiac disorders. We want vital signs, including orthostatic or postural vital signs as well. General appearance. I worked with a student yesterday from another campus who had been assigned a patient, and I asked him to do his physical assessment and then write it up. And I went in and I saw the patient, and there were immediate, just walking in the door and sort of looking around and looking at the patient, there were 10 words that came to my mind that would have described that patient and created in my mind, helped start to paint that picture of the patient and what was going on with the patient. And the student used 2 words. And so don't underestimate or how important that general survey, general appearance is, and what information can be gleaned from taking that time to assess the patient just by observation, even if it's at a distance. Your skin, while we're always worried about skin integrity issues, when we're talking about cardiac disorders, we're talking about the color of the skin, whether it's cyanosis or they're pale, the fingertips, what's the conjunctiva look like? Are they diaphoretic? They hot, cold, when to touch, things like that. The head, the neck and the chest in particular. Again, we're looking for work of breathing issues. We're looking for the shape of the trunk, the chest, if you will. JVD for fluid overload can be an issue. When we're doing our palpations, particularly for pulses, I got it, we're good. Don't forget, especially folks that you are assessing cardiac issues, palpating for the point of maximal impulse. We haven't spent a lot of time on this one maneuver in physical assessment, but if you have a patient who has cardiomegalia, meaning their heart shape has increased in size, actually that point of maximum impulse will change, and it's not where you expect it around that 6th intercostal space on the left. It can be down even further, 7th or 8th intercostal space with significant cardiomegalia. So those are the sorts of changes you're going to potentially see. Our heart sounds, we know S1 are the closing of the mitral and tricuspid valves. S2 would be the closure of the aortic and pulmonic valves. LUB is longer than the DUB. S3 can also be a sign of heart failure or some valve regurgitation. And again, for S3, we think the word Kentucky, Kentucky. So Ken is lub, tuck is dub, and the key is the S3 sound. Again, you're only going to start picking up adventitious sounds with practice. You need to know what normal sounds like. You need to know what expected S1 and S2 sounds like before you're going to start hearing and identifying S3s and S4s. So the more hearts you listen to, and again, you don't always know what that adventitious sound is the first few times you hear it, but until you practice, you might not even recognize or pick it up because your ears aren't trained. The S4, or an atrial gallop, is usually a sign of a hypertrophic ventricle. It's a lot stiffer. It might be a little bit bigger, and it's the atria having to fight its way with a more forceful contraction, if you will. increasing the turbulence of the blood flow. And we know where there's turbulence, there is a different sound. So you can auscultate that. That's what a murmur is, turbulent blood flow. And in the heart, it's invariably a sign of an incompetent valve. Whether a valve doesn't close entirely, doesn't open entirely. So when blood flows through, it's turbulent and you can auscultate that. And again, you only hear those really subtle changes with practice. And if you're going into cardiology, you need to listen to a lot of hearts, man, before you start hearing that stuff. Got to listen to the lungs. Certainly, there are lots of lung disorders that are unique and isolated to the respiratory tract, but we also know once you start getting heart failure, you're going to hear it in the lungs as well. With right-sided heart failure, your abdominal exam needs to be concrete. Again, you're looking for ascites, hepatomegaly. And again, I'm not huge on palpating edges of livers and things like that, but if that becomes your, if cardiology becomes your specialty, then you are going to start palpating livers and looking for edges of livers and things like that. Dependent edema, you know, what are people's ankles, feet, how high up, pitting, non-pitting? Has the color of their skin changed? Looking for signs of peripheral vascular disease, looking for signs of peripheral arterial disease as well. And if you need to go back and review that content from the spring, please do. Again, vascular disease is disease of the veins. You've got either incompetent valves, broken valves, lots of edema, arterial disease, blood flow is not getting down there. So your arterial disease periphery are going to be pale, they're going to be cold, they're going to have prolonged capillary refill. You're going to have when you have an injury or a wound, there's going to be slower healing because we're not getting good oxygenated blood to that end. Wounds are going to be dry. They're going to be distinct edges versus peripheral venous disease. Lots of edema. Skin's either very red or that sort of citron brown discoloration. Wounds tend to be moist, irregular edges. They may also be slow healing for other reasons. But again, venous disease and arterial disease looks different on physical exam. Peripheral pulses. You know, your shortcut is check your dorsalis pedis. If you've got a dorsalis pedis, you will eventually find the other lower extremity pulses on that limb. But if that one's absent, you need to really dig deep and find out where's the last strong functioning pulse. Get a Doppler out. If you can't feel it or you can't find it, get a Doppler out to see if it's there, or I should say to hear if it's there. Has anybody had a chance to use a Doppler in clinical?
I did on Monday.
Oh yeah?
Lab.
And tell us about the patient. Tell us, how did it go?
She was honestly had so much going on. She had Parkinson's. She had just done a BAB like a month or two ago. She was in for a TAVRs procedure, and she was very kind of unresponsive for the most part, but no talking and couldn't really move anything. But we were just checking all her pulses prior, and we honestly could not find either of her pedal pulses. So we pulled out the Doppler, and it took us a while on her left foot. We were really having difficulty finding it, but then we marked it so that anybody else could find it, and we could do it later once the procedure was over.
And how important that is, Linda. That's a good one. And you know, we talked about this, I know, in the spring. We write on patients with surprising regularity. You know, if you just spend a half hour, and that might be a bit of an exaggeration, but if you spent real time looking for that pulse, go ahead, mark it. They don't, you know, you don't have to make it so that everybody has to spend all that extra time. And it also documents that it was there when you started, because if they do end up going through a groin to do the cardiac procedure, that assessment's going to be critical moving forward, right?
Absolutely.
Yeah, all of our patients that come like after a stent or a coil procedure where they go through the femoral, the pulses on their feet are always marked with black Sharpie.
Yep, that's good, Jack. Thank you.
Mhm.
And so again, that's not just in cardiology. Those are neuro procedures going through the femoral artery. Again, and we've talked about this. I know you've been tested on it, far too often. That's really key to your post-procedure assessment. Can you really call the procedure a success? Well, maybe we prevented the aneurysm from blowing, but they lost their leg because of blood clots or arterial damage to the insertion site. Great. They're going to live long enough to know they lost a limb. I'm not sure that actually falls into the success category on some level, And so again, you're going to have to take all that information, try to create a picture of it, and figure out what's going on. And whether it's a valve dysfunction, coronary artery disease, a lot of these signs and symptoms can look very similar. So you need to put it all together, and then you need to use your imaging on top of it to see exactly what's going on with the patient. We talked last spring about lipid profiles and how important managing lipid values in the body are. It's as much a risk factor, it's as important a risk factor as any in cardiac disease, or I should say in vascular disease overall. Look at cholesterol and triglycerides, and then there's the high density lipids and the low density lipids, if you will. I prefer H, happy, for the good ones, L for lousy for the bad ones. You guys have, there's multiple different ways to remember those. And I present these ranges just as guidelines. You need to know your reference ranges wherever you're working.
Carolyn, quick question. Is lipid profile and lipid panel, are those two interchangeable?
Yes.
Okay, thank you.
The normal HDL LDL ratio is about 1 to 3, so they like to keep it above 0.3, and again, the ideal is above 0.4. And in terms, particularly raising the HDL, so raising your good cholesterol, if you will, what are some of the ways that a patient can do that?
Omega-3s, quit smoking, olive oil, exercise.
Those are all correct, Jack. Some of the stuff I've been reading lately really does talk about exercise and what a significant impact that makes on the HDLs. I don't know if you guys have read anything about that or seen that, but relatively small increases in exercise can make a significant difference in the HDLs, particularly in folks who are not already exercising regularly.
Purple vegetables,
I didn't know about the purple vegetables, but that's,
coconut oil.
oh, well, there you go. Then we have some other lab values, the BNP, or the brain nutrient peptides. So this is another lab that we talked about last spring, but this is when I say a good lab, you know, we used to have a lot of folks come in who are very short of breath, and they've got a history of coronary artery disease, and they've got a history of COPD, and they're short of breath, and you listen to them, and they've got some wheezes, they've got some rhonchi, they've got some rows, they've just got that whole washing machine thing going on in their lungs. And it's tough to tell sometimes, why are they more short of breath in this episode? Is it an exacerbation of heart failure? Is it, you know, an onset of pneumonia or exacerbation of their COPD? Well, your BNP helps differentiate that. Elevated BNPs are indicative of heart failure. So again, for these patients, particularly with dual diagnosis, respiratory and cardiac, it can be helpful to watch their BNPs. It's helpful for our patients, but I find it particularly helpful in the dual diagnosis respiratory cardiac patients. And I said the CRP, reactive proteins, again, this is a real sign of inflammation. And again, the role of inflammation in atherosclerosis is increasingly significant. Quick picture in terms of coronary anatomy. This one begins to show some of the coronary arteries, and we'll talk about that a little bit. All of a sudden now I can't remember whether it's today or tomorrow, but you know, these major coronary arteries are feeding the oxygenated blood to some of the most important muscle in the body, the ventricles of the heart. And where you get a blockage in these arteries is where you're going to have your coronary ischemia, where the damage in the heart wall is going to take place, and that can be diagnosed by a 12-lead EKG. You can literally see which real estate is being impacted by ischemia on your 12-lead EKG. So whether you call it an ECG, EKG, I think I typically use EKG. There is a resting EKG or a 12-lead. And this is the one where patients laying in bed, they get hooked up to a machine. It seems like there are a whole lot of wires, and they get taped to the patient, and the machine does its thing, and out pops a usually white piece of paper with red grid on it and a squiggly line that looks like a heart tracing. Has anybody had a chance to do a 12-lead EKG for a patient?
Yes. Well, to watch it, to see
Yeah.
how it was done, a couple times now, up at UConn.
Yep.
And one time over at Yale.
Do you know why they were doing it, Kristen?
Well, one of them, the one at UConn, it was like we were about to leave and it was just something different. So somebody pulled me. So I'm sorry, I can't remember. But for the one at Yale, it was somebody who had a stroke. They had the second stroke and they'd coded on me. That was last semester. And they'd gotten checked down with an MRI and whatnot. And then I don't know what happened afterwards, but we were going upstairs and they did an EKG on him as well, because, you know, he had all the typical unholy trinity, you know, the HLD and the risk for diabetes and HTN. So they were trying to see if there was cardiac involvement with the stroke.
Got it.
Carolyn, we
Yep.
had a case up at Yale. This woman, a 72-year-old female, history of AFib, with periods of VTAC, and she was just lying in bed, and her heart rate went from 70 to 180 with doing nothing, just lying there. So we put a 12 lead on, and we did a manual blood pressure. They didn't want the electronic. They wanted a true blood pressure.
Yeah.
So we did, Marion and I did the right arm, and we just could not get a blood pressure on the right arm. So they went to the left arm and was finally able to get one, but she was a hot mess. They were using beta blockers, ACE inhibitors. Her BNP was at 23,000,
Okay.
and normally anything over 100 is bad news. So they put her on amnio, and it's almost like it was a light switch. Like 4 minutes later, her heart rate came down into 80, 90, and she stabilized. And, you know, she was stable for the rest of her time at the unit.
Oh, good. Yeah. So it's this. I think, you know, that's almost the kind of patient. I don't mean to say but I do enjoy cardiology. It's just, it's so interconnected, and it's interesting. But
We do EKGs for patients starting Reglan. I think they get one before they go on it, and then they get one like after a dose or two.
for Reglan, Jack.
I think so, yeah. And just like some other new medications that might cause like differences in.
It changes, yeah. Well, I mean, there are definitely lots of medications, and the ones that you have to be careful of a bunch of things, but the ones that impact the QT,
Hyperchlora, whatever, that's what Trump was trying to push for.
there's certainly a lot of, like, the MAOs impact the QT timing as well, so you have to really worry about those. So
To go
again,
off of Jack's, the Reglan does have the opportunity to prolong the QT and the risk for arrhythmias. So we actually do them over at Stanford sometimes as well.
good to know. Thank you. So again, your 12 lead is your patient's laying down, you hook them up, you do it. You know, everybody needs to be sort of staying still. They don't need to stay still for a long time, but pretty much a minute will get you a good tracing, and then you take it off them and you move on. Then there's continuous EKG monitoring. And a Holter monitor is where a patient gets hooked up, and they're going to do, usually it's a 24-hour test. The old Holter monitors used to look like a pocketbook. Now it looks like a thumb drive. They keep it in their pocket. They have their leads. They do their thing for 24 hours, and then they drop it back off at their cardiologist's office. You've had patients on telemetry, patients who are being transported via EMS can go on telemetry. And that is a form of continuous EKG monitoring. And then there's exercise or stress test monitoring. Again, you hook the patient up to essentially telemetry, and while they're being tested, each of the 12 leads are monitored to see if there's any changes in the tracing. And we'll talk about what those changes are over time. So again, EKG monitoring can take a couple of different forms.
At Yale, we only have 10 electrodes that we apply. Why is it called 12 lead?
Oh, I'm so glad you asked that question, Jack. That's very good. Give me a little while and I promise we'll get there. Can you wait that long?
Yeah,
Excellent.
because I've done them, but
And you spent 5 minutes looking for the other 2 leads, didn't you?
yeah, I asked the PCA because she was
Yep.
showing me how to do it. And it's pretty easy, I guess. You just put one on each extremity, and then the other 6 go down around the heart.
Green and white on the right, Christmas trees below the knees. We'll
When
get
we do
there
the-
too.
when we do the 12 lead, they're not even colored. They're just labeled.
Why would
Doesn't
you
it-
stop and read when you can just do green and white on the right, Christmas trees below the knees? Or some people do smoke over fire, snow over grass, or some such nonsense
They're
like
just like
that.
little sticky pads. They don't even have the metal prong on it on my floor.
Okay, but I promise we're going to get there, Jack. Hold that
Yeah.
thought. Other problems of the heart are infectious problems. Infections of the endocardium is called endocarditis, pericarditis, and when we're talking about major involvement of the heart, it's rheumatic carditis. And as you can imagine, these infections can be severe, and if the patient survives, you can have long-lasting problems. Endocarditis is an infection of the endocardium, and it very typically involves the valves. And high-risk populations are folks who have a history of intravenous drug use, people who have a history of valve replacement, existing mitral valve prolapse, other structural cardiac problems. After dental procedures is a particularly high-risk period for folks with valve problems or people with implants in their body, think joint replacements and things like that. And anybody who has a systemic sepsis infection is at risk for endocarditis. So think of it like this. All right, somebody got a little infection somewhere, and the bacteria managed to get into the bloodstream, and it's just traveling around, looking around to see what neighborhood it wants to pop into. It gets to the heart, and there's all this blood moving, and it's going fast, and you're going from one area to the other, being squeezed through. The bacteria holds on to one of those valves, saying, moving too fast, and it stays there, and it starts to replicate and starts to grow. And you end up with literally little growths, sometimes big growths, on valves. And that is what becomes endocarditis.
Carolyn, I have a question. Is this why some folks who have heart murmurs have prophylactic antibiotics prior to dental procedures?
Absolutely, yes.
Okay.
And again, not only like replacement valves, but folks who have had joint replacements and things, it makes them at greater risk for just infections at those in those areas. Endocarditis is typically caused by strep infections, staph infections, E. coli, pneumococci, and fungus. And here's a quick little picture of where it just, again, it gets seated in those areas in the endocardium, quite near the valves. And on ultrasound, all those little growths can be seen. So these folks have an infection. So they're going to often look like they have an infection. Fever, night sweats, sometimes quite a high fever too. Anorexia, weight loss, fatigue, pain, that back joint pain, malaise. Again, looking like they've got a fever. The bigger those growths get near the valve, the increased risk of dysfunction at the valve, which means they're going to start hearing cardiac murmurs. Once the valves start to fail or become increasingly incompetent, you end up with heart failure. So you'll be looking for those signs and symptoms also. If those growths get particularly large and a piece breaks off, now you've got an infectious emboli traveling throughout the body. And it's called vegetation. And I always, that sort of just like skeeves me out to think that there's an embolic vegetation traveling through a body. And we know any embolism can cause a stroke or an infarct, whether it's in the brain or other areas, other organs of the body. What you start to see are these splinter hemorrhages. They look like there's almost splinters underneath the nails and at the nail beds. Janeway's lesions, it's funny, with all the endocarditis I've worked with, I've never seen Janeway's lesions. And I meant to get a picture and I don't know if I remember to do that. But you'll see petechiae, which we've talked a lot about. Petechiae doesn't usually move to purpura. It usually stays at petechiae. On the break, we'll look for Janeway's lesions if I don't have a picture. The deal with endocarditis is it takes a long time to treat. Again, as with most infections, you start the antibiotics. Once you've collected all your cultures, you start with a broad spectrum antibiotic. And once the cultures come back, you can narrow it down, become more specific. But you're looking at IV antibiotics for anywhere between 6 to 12 weeks. And who did I say was one of the major risk populations for endocarditis?
Say patients with sepsis.
There, yeah. Who's at the top of this list? IV drug users. Is that the kind of population you want to send out with central line access? Central line IV access?
Hell no.
Yeah, no.
But
It takes a whole nother level to manage those patients with IV access.
if you're thinking from the public health initiative that you can't stop their addiction, you can only make it safer, then maybe that is a good idea to let them out there with access.
Mm.
Like a clean needle program.
But it's like it had the extreme risk of overdose because they'll be going straight to their heart.
No, I know. I'm just playing devil's advocate. Kind of.
Yeah, I understand with the needle exchange program, but I hear what you're saying. But also, people who are high probably can't. Let's stick with the needle exchange program, Jack, because most folks who are high cannot manage the aseptic technique required to manage a central line. And so that was the sort of thing, when, again, you've heard me talk about my HIV population in New Haven, what the vast majority were IV drug users. And we would contract with them when they were more sober. You know what, I'm not sure I can stop you or keep you from using intravenous drugs. I hope to. Please let me help you. Let me try to help you. But for the love of God, please don't use the IV we need to place for your treatment. If you are outside, you would have to find a place to inject. Keep finding those, and again, we didn't say it quite like this. Keep finding your own placements. Please don't use ours. And we had some fair success with that, but you need to know your patients. So again, long IV antibiotics, obviously, I won't say obviously, but best managed with central or long-term access. We don't want these folks in the hospital for such prolonged stays, so we need to help educate them. How do you do antibiotics at home? How do you manage your IV access at home? What happens when you need prophylactic antibiotics and things like that? And if the valves become severely damaged, they may need to be replaced over time. And once you've had endocarditis, you do tend to be at risk for developing it again, which is unfortunate, to say the least. Pericarditis is inflammation of the pericardium. That's the sac around the heart. It can actually be chronic, but it can also be acute. It is one of those symptoms, complications of cancer that's seen as well. So a patient with pericarditis, especially with fluid buildup, you worry about cancer if they haven't already been diagnosed. If they have been diagnosed, it's almost like a pleural effusion, pericardial effusion. It's just one of those places where with cancer, that risk increases. And you have to is it an infectious pericarditis or is it inflammatory pericarditis? And again, you get a sample of usually fluid or tissue, and you sample it and you check to see if it grows anything. How are you going to, what are some of the signs and symptoms? Well, friction rub. A friction rub with the heart, again, it sounds kind of like sandpaper, and it goes with the heartbeat. A pleural rub goes with breathing. So again, you need to listen carefully to differentiate the two. And again, a pericardial friction rub is going to be timed with heartbeat, not with breathing. Pain, usually with inspiration, usually improves when the patient sits up. I'm sorry, it's worse with inspiration. And it gets a little bit better when they sit up and they lean forward. Might have a fever, might have elevated white blood cells. Again, all those signs of inflammation are possible also. And some subtle EKG changes. We want to manage their pain. We use anti-inflammatory agents. If it proves to be infective, we use antibiotics. If there's excess fluid, hi buddy, thank you. You too, take care. If there is a fluid buildup, they can tap out the fluid with a pericardial centesis. And for recurring pericardial effusions, you know how we talked about the pleural effusions, they'll leave a Denver cath in there that can be open to drain the pleural effusions periodically as the fluid builds up. Well, they don't really want to leave a catheter in the pericardial space. They may do it, but that's not usually their preference. But they create what's called a pericardial window, which helps drain the fluid into the pleural area, which drains out, it gets absorbed, and it just doesn't build up in the heart. Because remember, again, with these effusions, whether it's in the pericardial sac or the pleural area, that's taking up valuable real estate that's necessary for healthy functioning of the heart or the lungs. So draining that fluid is kind of important. Okay, we'll also use diuretics, digoxin to strengthen the contractions of the heart. And as I said, pericardial window. And a pericardectomy is where they sort of remove some of the pericardium to make an even larger pericardial window. Rheumatic carditis. Again, this isn't usually infective, caused by streptococcus. This is, again, affects the myocardium of the heart from a infection perspective. It is usually a legacy infection from untreated streptococcus infections when they were children. It's usually seen in older adults. Nowadays, we can treat strep infections. We're good at treating strep infections. So we really don't see this near as much as we used to. Similar signs and symptoms as with a typical strep infection: fever, chills, sore throat. That exudate in the back of the throat, which is red and angry looking. Enlarged and tender lymph nodes in the neck and head region. Recurrent otitis in children. Abdominal pain. Again, ultimately, our biggest problem is it results in valve damage and may require either long-term penicillin or whatever antibiotic is working, and valve replacement or repair is important. Again, these folks need prophylactic antibiotics for other procedures, especially dental work, other surgeries and procedures. And again, do you remember, why is dental work such a high risk for folks with these pre-existing conditions?
The extensive amount of bacteria in your mouth can be easily dislodged.
Exactly, that damn filthy mouth again. All right, why don't we take, let's see, 10:36, go 10:40. Why don't we all come back around 10:50 or so? Let's take a quick 10-15 minute break. And then we'll come back and we'll start with valves. Think of any questions and I'll see you on the rebound, okay?
Sounds good.
See you soon.
Okay.
Thank you.
My pleasure. Ooh, record. And I did take a minute to go and get a picture of those Janeway lesions. They are these flat erythematous or hemorrhagic macules, usually found on the palms and the soles. And so that's what they look like. And let's see, now we're going to move into valves. You guys are there? I'm not talking to myself. Okay.
We're here.
I'm talking to myself. Who cares?
Here.
What else is new, right? So we know some of the valves are 3 flaps. Some of the valves are bicuspid or versus tricuspid. Again, 3 flaps versus 2 flaps. And the work of the valves is to keep each compartment within the heart as a closed, intact entity while it's, or I shouldn't say that, to keep blood moving in one direction when the heart's either filling or contracting. And it's trying to keep blood organized and moving in one direction. So when the valves are incompetent or not closing properly, it allows blood to go in an opposite direction, which messes things up like crazy. So again, you need to know which valves are impacted. You need to know, because that tells you in location in the heart where the problem's going to be. And if they're stenotic, means they've gotten smaller. There's stenosis, making it smaller. And regurgitation means it is incompetent when it closes. So let's go back a little bit. And again, here is your aortic valve. In my world, the aortic is the easiest to remember because it's the one coming out of the left ventricle that keeps sort of the gate between the aorta itself and the left ventricle. Your mitral valve is between the left ventricle and the left atrium. And then you have the tricuspid valve between the right atrium and the right ventricle. So again, let's just, not necessarily going down the specifics, but let's think about what happens if the aortic valve is stenotic. It has gotten smaller so that the blood flow from the left ventricle out to the aorta is impeded because, again, the aortic valve is stenotic. What does that mean? What do you think can happen? What does the left ventricle have to do if the aortic valve is stenotic?
Pump harder.
Pump harder. Good. And so what's going to happen to the myocardium of the left ventricle?
Hypertrophy.
Exactly. And so, and actually could be one of two things, Jonathan. It can either get really thick and stronger, or harder, if you will, and that might make the left ventricle, the sac itself, smaller because the myocardium is taking up more space, or can make the heart bigger, or if no matter how hard it's pumping, there's still always blood left in the left ventricle, it can get sort of floppy because it's overstretched. Do you see how those, so that's also a possibility. It's like overfilling a balloon. And you know how once it does empty, it's just sort of saggy and floppy? That can happen to the left ventricle also. And again, so if the mitral valve is not working, that means the blood flow between the left atrium and the left ventricle is impeded. What happens if the mitral valve is incompetent? What happens when the ventricle contracts if the mitral valve doesn't work?
Backflow.
Regurgitation.
Regurgitation, right. Which means when it's supposed to be filling with fresh blood out of the pulmonary vein. There's this blood coming back from the left ventricle, already taking up space in the left atrium. Blood can't get out of the pulmonary system because there's already something in the left atrium. So it has to sort of sit around in the lungs and wait till the next time to get in. And I make it sound like it's a this happens, then this happens, then this happens, when we know it's a much more continuous flow. But the bottom line is not as much blood can get out of the pulmonary system because the left atrium is already got some blood in it when it was supposed to be empty. What does that sound like? What does that result in? Blood sitting.
Turbulence?
Hold on,
Left-sided
Kate.
heart failure.
What kind of heart failure? That's it's the left atrium that's malfunctioning.
Oh, right-sided.
No. You were right. I think you said left side. It's left-sided heart failure.
I was wrong when you said that. Okay.
I'm sorry. Left-sided heart failure. You got a malfunction of the left side of the heart, in this case, the mitral valve, and that results in, what the hell? Sorry. And that results in pulmonary edema, congestive heart failure, and that's left-sided heart failure. Okay. So again, just if you think that through with that picture in your mind, I found that was helpful to me when I was first sort of had these pictures drawn for me. So again, stenosis is a narrowing, constriction, getting smaller, changes the amount of blood that can be moved through that valve. It can be caused either because the leaflets don't fully open or close. The area can get thickened. There are a couple of different reasons for stenosis. And again, when a valve closes, it should close tight. It should open wide. And so, and here's just a illustration of when there's a stenosis on closing, and especially when it opens. It's just not competent, if you will. Again, regurgitation is when there's, again, not complete closure, and with constriction, blood flows backwards, and it's always supposed to be moving forward, it's supposed to be moving in one direction. Whether a calcification, other congenital factors, rheumatic fever, endocarditis, all sorts of reasons and causes for stenosis. Women have a greater risk of mitral stenosis, mitral valve problems in general. The older you get, the greater the chance you're going to have aortic valve problems. And these chordae tendineae, I've mentioned those at least once before, but let me go back here with this picture. So here are the valves, and they're actually connected to the mitrum by these chordae tendineae. These are what keep the valves in place. And this is another risk factor when we get to myocardial infarctions and ischemia. If that muscle wall weakens and the footings or of the chordae tendineae rupture, come loose, that's another way you can get acute valve dysfunction. And you get acute pulmonary edema, and that's a really significant risk. And that's why with myocardial infarction, listening to heart sounds for developing murmurs is really important. If one of these tendons ruptures, the valve goes to hell, and you've got the risk for flash pulmonary edema is significant. And it all goes back to assessment. I know you think I'm batshit crazy when I'm always talking about assessment, and going back and checking and rechecking. But these changes happen very quickly. And while the change might be subtle, the results are not always subtle. So what's mitral valve stenosis look like? Again, shortness of breath. It's going to look like heart failure. They'll have exertional dyspnea on exertion. They're going to have a louder S1. They'll have a murmur, tired palpitations, chest pain. Obviously, in extreme, they can have stroke symptoms. Sorry, my finger is having a problem. When we have mitral valve stenosis, again, because there's backflow from the left ventricle, that increases the pressure in the left atrium. You have decreased blood getting out of the pulmonary system. That increases the pulmonary artery pressure. And again, it looks a lot like heart failure. Also results in pulmonary hypertension because the heart's working hard, but the lungs are holding increased blood flow. You get the heart enlargement, pulmonary edema, increased risk of atrial fibrillation, and we know the risks of that. Blood clots related to the atrial fibrillation. Blood is pooling in the left atrium. After with the atrial fibrillation, it's not getting the blood out, not keeping the blood moving. Again, murmurs, shortness of breath, very common. If mitral regurg becomes chronic, you end up with ventricular hypertrophy as one of the potentials. Again, this can also result in decreased cardiac output. The walls of the myocardium get thicker, decreased filling of the ventricle because smaller size, and that just results in decreased cardiac output. Cardiac output, that formula is stroke volume times heart rate. So if the volume of the filling of the ventricle is smaller, you either need increased heart rate or you're going to have decreased cardiac output. So that's, and again, those tends to result in fatigue, tachycardia, shortness of breath. Over time, you'll develop an S3, which again, as we said at the very beginning, is also a sign of heart failure, those additional heart sounds. A murmur with the blood backing up through the valve, the turbulent blood. Patients can initially be asymptomatic. It can be very mild, but those patients need to be monitored to make sure it doesn't progress either slowly or suddenly. And you try to fix the valve before you develop changes in the remodeling of the heart. That's the phraseology that's often heard now, remodeling of the heart. And remodeling, it reflects the changes to the myocardium, the size, and things like that. And pulmonary hypertension is actually very difficult to manage, especially primary pulmonary hypertension. There's some medications, but there's really no surgical procedures to mitigate pulmonary hypertension. Mitral valve prolapse, again, this is what's so common in women. It's when the leaflets are slightly abnormal, and whether it's the muscles or the chordae are imbalanced so that the leaflets are not, well, I guess they're intact. It can be closed, but again, if it's supposed to be, I think it's supposed to be rounded up when it's closed. It's more of a flat area, and literally they prolapse. And so long as the leaflets are closing intact and completely, it's not a problem. But over time, you get incompetent closures, you get regurgitation and things like that. And so again, it's something to be monitored. Always check your heart sounds. You're looking for that regurgitation and that turbulent blood flow. Way more common in women. Can over time develop a diastolic murmur. Can get worse at periods of stress. And when it gets worse, there can be angina, shortness of breath, syncope, palpitations. And again, monitoring the prolapse and trying to identify it prior to becoming a significant regurgitation is important. But in general, prolapse patients are going to be asymptomatic until they're developing the regurgitation. And that's the regurgitation means the leaflets are not closing competently. If there is regurgitation, patients are going to need antibiotic prophylaxis for procedures. They may use beta blockers to control palpitations or chest pain. They should avoid caffeine, again, avoiding situations where they become tachycardic. No over-the-counter stimulants. Exercise is important. Developing tolerance definitely helps. And then what are the signs and symptoms to call their healthcare provider? And what do you think some of those signs of symptoms would be for somebody to call?
Angina or dyspnea?
That's exactly right, Jonathan. Very good. So aortic stenosis, I sort of talked about that, but again, that's the aortic valve is stenotic, it's smaller, it's causing obstructed blood flow up into the aorta, creating an emptying problem in the left ventricle. Can be congenital, rheumatic fever, but the most common risk factor, in fact, is aging. The older you get, the greater the chance of aortic stenosis. We talked about this. Over time, you end up with a weakened left ventricle. And again, in this case, blood's not getting out to the body. It's having a tough time pushing its way into the aorta. When you're doing your assessment, typically you're going to hear a softer S1. There may be a systolic murmur. S4 can be here, and angina, syncope, DOE, and heart failure are the most common signs and symptoms of aortic stenosis. I love that classic triad, and I've got 4 things listed there. That's a problem. Yeah, sometimes when I type this stuff, I don't know what I'm thinking. I apologize. I do know that triad means 3. Aortic valve problems are very complicated. They can't be fixed. They tend to get worse, and you have problems. If you're using things like nitroglycerin, which is going to dilate our arteries, it actually reduces blood pressure, and that can make your chest pain worse versus making it, improving it. And we often use things like nitroglycerin to vasodilate to help improve cardiac blood flow. But it can have almost the opposite effect in folks with aortic stenosis and aortic valve problems. We talked about these sort of dysfunctions of the anatomy of the valves. We talked about how regurgitation has blood going 2 ways through the valve when it's supposed to be one direction. With aortic valve regurgitation, the blood goes back into the left ventricle when it's at rest, and it's supposed to be filling, but in fact, blood can be coming back from the aorta into the left ventricle. Again, meaning that the left atrium can't empty because the left ventricle didn't empty. In an acute situation, it can be caused by endocarditis, an infection of the aortic valve, could be traumatic. Aortic dissection, where there's a problem with the aorta itself. If it's high enough, it can come right up to the aortic valve, and that tends to be life-threatening. None of those remodeling systems have had a chance to happen. So when you have an acute problem of the aortic valve, that is an emergency. There's no compensatory mechanisms that have developed to support a poor functioning aortic valve. With chronic aortic regurgitation, because that's usually happened over time, different compensatory mechanisms will develop. Again, you get that cardiac remodeling that can help mitigate some of the worst symptomology. It's not fixing it, it's sort of problem solving, putting a Band-Aid on it, if you will, just to keep the symptoms at bay. But again, you don't have that with an acute problem with the valve. Some of the causes of chronic could have, again, rheumatic heart fever, heart disease, I should say, congenital problems, syphilis changes, causes long-term changes to the aortic valve, calcification of the aortic valve, again, usually related to age. With that backflow of the blood into the left ventricle, you end up, again, with left ventricular dilation, remodeling of the muscle. As the muscle gets more hypertrophic, its contractility can go down also, which long-term causes decreases to cardiac output, pulmonary hypertension, right-sided heart failure. Again, acute aortic regurgitation is an emergency. Folks have severe shortness of breath, chest pain, hypotension, cardiogenic shock, need to be dealt with quickly. Chronic, the symptoms get worse over time, often get worse over time, but as I said, they end up developing compensatory mechanisms if given enough time. Tricuspid and pulmonic valves over on the right side have fewer problems, and they more often have stenotic valves versus regurgitation. Can be seen with patients with rheumatic fever or history of IV drug use. When you have increased right atrium enlargement, that also causes atrial fibrillation, can increase, or it creates a bit of a backup in the right-sided heart system. And so when the right side of the heart's not functioning efficiently, where does the blood back up when the right side of the heart's not working?
Lungs.
You'd get maybe ascites,
Yep.
jugular vein distension, hepatomegaly.
Yep. So the blood is coming from the liver's like the last big train station before the train, think the blood, moves to the right atrium. So if the right side is not working effectively, the blood's going to pool in the liver. Hepatomegaly, ascites, peripheral edema, that's all those signs of right-sided heart failure. Again, anytime you have valve dysfunction, right, left, stenosis, regurgitation, you end up with murmurs. Some of the best ways to diagnose valvular heart disease, certainly listening for murmurs, listening to heart sounds. In the past, ultrasound was important. They will often start with ultrasound, but CAT scans are more and more definitive of valve for diagnosing valve disease. Chest X-ray gives you a sense of blood pooling in the lungs, size of the heart, and things like that. EKG can also show changes in some myocardium contractility, and cardiac catheterization can measure blood flow and pressures in each of the different chambers of the heart, which is also important. Again, if you think back to pediatrics, particularly with things like tetralogy of Fallot and some of those combination congenital problems, which way, whether you have a right-sided shunt or a left-sided shunt, or which direction blood is going to go, really sort of depends on the pressures in each of the chambers. And that's where cardiac catheterization can really measure those pressures in each of the chambers during each of the phases of contraction and filling, rest, and things like that of the heart. In general, folks with valvular disorders need prophylactic antibiotics for procedures and often to suppress repeat infections, particularly if they have infectious endocarditis, a history of infectious endocarditis, I should say, or recurrent rheumatic fever. You have to monitor for heart failure, pulmonary edema, thromboembolisms. Managing heart failure, we've talked about that a lot. We use both vasodilators, although again, with the aortic stenosis, you have to be careful and make sure that you're not dropping blood pressure too low, because we're already having trouble getting blood out. So vasodilating may potentially even decrease further blood flow. ACE inhibitors are helpful to control blood pressure. Digoxin are used as a positive ionotrope. Diuretics to help keep heart failure under control. And beta blockers to improve cardiac output. If fluid balance is an issue, we watch our sodium intake. People with AFib and significant murmurs may be on prophylactic anticoagulants. They're more and more using the oral anticoagulants like Xarelto, Eliquis, things like that as anticoagulant therapy. But once you have a valve replacement, once you have a valve, then you need to go to either Coumadin or Lovenox or one of the other low molecular weight heparins. The Eliquis, the factor 10 anticoagulants are not effective enough with valve replacements. Anti-dysrhythmia drugs, particularly to manage atrial fibrillation. In terms of treating valves, this percutaneous transluminal balloon valvuloplasty has become the more common procedure at this point in time. They can use balloon valvuloplasty to open valves, to open stenotic valves. Again, they're just threading a catheter through up to the valve area, inflating the balloon, and this can literally increase and open those areas to improve blood flow. Decreasing the stenotic, making that opening wider. They do worry about emboli being released. That's one of the big risks to balloon valvuloplasty. But again, it looks very like a cardiac catheterization, but instead of going to the coronary arteries, they're going to the valves, larger balloon to just open up that valve and to sort of separate the leaflets of the valve. A surgical procedure, whether it's an open procedure or minimally accessed procedure. They can do repair on valves. They can do replacement of valves nowadays. The commiserotomy or valvulotomy, these are where patients need to have their mitral valves opened and to improve the function of the leaflets. Valvuloplasty is a minimally invasive procedure. Prosthetic valves, we talk about whether they're mechanical or biologic. The mechanical valves last longer, but they have a greater risk of thromboembolism. Again, requires long-term anticoagulation. Biologic valves are either from animals or from humans. Those do not require long-term anticoagulation, but they don't last as long. And if you're looking at particularly aortic valves, you have to be an aortic dissection, which we'll talk about later. With the dissections, you need to make sure the dissection is not so extensive that it extends into where the aortic valve is foundation into the myocardium. So sometimes fixing a dissection requires a replacement of the valve also. Whether they choose to use a biologic valve or a mechanical valve depends on a number of different things. Should a patient be taking anticoagulation? Again, if it's a younger woman in particular, childbearing age, they prefer a biologic valve because it gives them a chance to more easily have a child. But yet a mechanical valve is going to last longer, so it tends to be a better option in some respects for a younger patient. As patients get older, durability is less important, but you have the, again, increased risks of anticoagulants. So again, it is a, you have to weigh each situation for each patient. And again, going back to our assessments, history of rheumatic fever, history of infectious endocarditis, any signs of congenital defects, history of myocardial infarctions, traumas, cardiomyopathies, other infections like syphilis, connective tissue disorders like Marfan syndrome. These are some of the big health risks for patients. When we're doing our assessments, again, when we're looking at our functional health patterns, what do they do in terms of health management? How do they perceive their health? What's their activity and exercise levels like? What symptoms do they have? What prevents them from doing exercises? What helps them do their exercise? What happens when they're sleeping? How much sleep do they get? The quality of their sleep? What bothers their sleep? Things like nocturnal dyspnea. Do they have other signs of pain like angina or other less typical complaints of discomfort? We obviously worry about fever. We worry about night sweats, diaphoresis, color of the skin. We know clubbing is a sign of a long-term compromise of the system. Peripheral edema, respiratory assessment, listening for adventitious sounds, listening to heart sounds, trying to pick up abnormal heart sounds, rate and rhythm, trying to determine dysrhythmias. And so again, anytime you're documenting a heart rate, it's rhythm, regular, irregular. And when we're talking about irregular, is it regularly irregular or irregularly irregular? Those, again, it's easy enough to nowadays to hook up to telemetry, look at a 12 lead, things like that. But in the past, that was the sort of written documentation that helped paint a picture of your patient. When you're doing your blood pressures, documenting pulse pressures, that difference between systolic and diastolic and what's happening to that trend. Sort of hypotensive episodes, again, postural signs. How many folks are subject to syncope and postural hypotension when they move too fast, when they change positions? So let's get a baseline on that and help patients learn how to move safely, how to change positions safely. Moving down to the GI, again, is the liver palpable? Is there signs of ascites? Is there an unexplained weight gain? Nursing diagnoses can decreased cardiac output, valvular incompetence, as evidenced by murmurs, dyspnea, dysrhythmias, peripheral edema, excess fluid volume related to fluid retention, and valvular induced heart failure, peripheral edema, weight gain, adventitious breath sounds, JVD. Those are some of your 3-part nursing diagnoses. Activity intolerance, insufficient oxygen, secondary to decreased cardiac output, pulmonary congestion, weakness, fatigue, shortness of breath, changes in heart rate, blood pressure, and then deficient health knowledge, particularly with new diagnoses, trying to make sure a patient has as much information as they need to understand what they can do to help themselves and what they should be looking for. We certainly want to maximize activity tolerance. We want patients to be able to live their lives with normal cardiac function. So what do they need to do in terms of health maintenance? So they need to understand what signs and symptoms they need to be looking for. They need to know how to use their prophylactic antibiotics. They need to share their health history with all their clinicians, their dentists, their specialists, all the way across the board. And again, looking for those signs and symptoms of increased problems. Shortness of breath that lasts longer, doesn't go away as easily. Changes to the way they're sleeping. Do they now need a pillow? Are they sitting up more? Are they not able to do their exercise routine the same as they did? Do they get that sort of vague chest discomfort or frank chest discomfort, as that may be? Big ankles, weight gain, again, those sorts of things should inspire them to call their health provider. During acute symptoms, they need to be able to rest. They need to know how to manage their exercise. They need to exercise within their tolerance levels. And hopefully they can build up strength, but know how to avoid what's too strenuous. Don't start smoking, don't keep smoking. Can't say that enough. If they're on anticoagulation therapy, there's a boatload of education that goes with it. What are some of the things that you can think of when folks are on anticoagulation?
Soft bristle brushes
Good.
and electric razors.
Yep,
No rectal temps.
right. If they're on Coumadin, anything special? Anything additional?
Be careful of MAOIs, I guess.
Don't they have to keep like a consistent diet of green leafy vegetables? You can't increase or decrease a lot from what you're at.
Yeah, that is, I'm going to come back to you in a minute, James, but you're right, Robin. Those consistent green leafy vegetables, those vitamin K holding vegetables. MAO inhibitors and anticoagulants. That one didn't come to my mind. I need to look that one up, but I'm going to.
I think they said that you just have to be careful. I don't think they precluded it. I know last when we did the 4304, we talked about not doing it, but I think more recently it just said if you're doing it, you just have to be careful.
I know there are lots of, I know the MAOs have a lot of cardiac symptoms. I don't remember it being an issue with Coumadin. I'll have to look that up on our next break if that's okay. But again, the other thing with Coumadin, they need regular measurement of their INR, whether they're going to a lab or they have a machine in their house, however they're doing that. The INR needs to be checked to ensure it's in therapeutic range. They need to report falls. Again, in the elderly, if they've got unsteady on their feet, you know, that's just a nightmare waiting to happen. It's really awful. The risks that are potential, you know, as patients become increasing fall risks. We certainly worry about it when they're in the hospital, but it's just as big a deal when they're in the home. It's just not necessarily under our control or under our care, but it's still a risk to the patient for significant damage for sure. Okay, cardiomyopathies, again, we are talking about subacute or chronic changes to the cardiac muscle. You don't typically cure cardiomyopathy. You try to mitigate or palliate the symptoms. And cardiomyopathy has a fairly significant mortality rate. About 50% die within 2 years of the onset or while they're awaiting transplant. We have dilated, hypertrophic, and restrictive cardiomyopathies. Those are the three types. Dilated is, you know, dilated meaning make it get big. It's where the heart just gets bigger, the walls get thinner, they get less strong. Hypertrophic, the walls get thicker, the space in the chambers gets smaller. And then restrictive cardiomyopathy is usually there's some sort of change to the flow, sometimes in the septums. There's some reason why the myocardium isn't stretching as effectively. They're stiff, just not necessarily bigger for some reason. It's definitely damage to the myocardium itself, the myofibrils being a smaller building block in the myocardium, the muscle. It causes changes to the way the fibers move, what their metabolism looks like. When you change the myocardium and its function, you end up with systolic dysfunction. blood's going to end up sitting in the ventricles. We know sitting blood is a huge risk factor. And over time, it leads to congestive heart failure. When we're talking about dilated cardiomyopathy, one of the biggest risks is alcohol use, excessive alcohol use. Coronary artery disease, recurrent myocardial infarctions are also risk factors for dilated cardiomyopathies. Autoimmune disorders, it can be a function of a postpartum syndrome. There are viral agents that cause dilated cardiomyopathies as well. And some of them are idiopathic, meaning we don't know what the ultimate cause was. Hypertrophic, again, thickening of the ventricles. The ventricles also get smaller, which impacts cardiac output. You can have septal thickening. This idiopathic hypertrophic subaortic stenosis, this is where the septal wall, particularly near the aortic arch, the aortic valve, is impeded. And we've talked about this a couple times, but when you've got your young athletes who drop in cardiac arrest, they're often found to have idiopathic IHSS or hypertrophic cardiomyopathy. It's unfortunately one of those things that's not always diagnosed timely. It's often asymptomatic, and it's not until there's some significant compromise, severe workout, hypovolemia, things like that, that causes an alteration in their baseline that ends up creating such a problem, leading to cardiac arrest. Folks with hypertrophic cardiomyopathy, some of their symptomology are chest pain, dysrhythmias, and as I said, sudden death. There is sometimes a genetic link there. It's less common than dilated cardiomyopathy, but certainly not uncommon either. And restrictive cardiomyopathy is even less frequent. And again, the heart muscle, the myocardium, is stiff. It's not flexible. It's not a change in the size of the myocardium or the muscle. It just doesn't fill effectively. It doesn't move. It doesn't stretch. And this leads to diastolic failure. These folks often present with dyspnea on exertion. The treatments are often symptomatic. Treating the symptoms are for palliative care. So you're going to treat the congestive heart failure. You're going to manage myocardial ischemia. Depending on what's the original causes are and the underlying concerns are, currently the most effective treatment is heart transplant, which comes with its own challenges for sure. Other interventions we have nowadays are implanted ventricular assist devices, LVADs. In the early days of VADs, they were used as what they called bridge therapies, meaning the heart is failing, they need a transplant. We don't have a heart available now. So they would implant the VAD until they got the heart. Over time, though, VADs have become what they call destination therapy. They're not, the patient may not be a great choice for a heart transplant. They may not even be eligible for a heart transplant, but the VAD is seen as a long-term or destination therapy for many patients nowadays. They require anticoagulation. The VADs are run by electricity or a battery source, so they need to be recharged. Patients need to keep their batteries charged at all times. We know Dick Cheney, a former vice president, had a VAD, and he was ultimately transplanted afterwards and is, by all accounts, doing well. Wasn't at his last health checkup, but nonetheless. Certainly both VADs and heart transplants, I'm not going to say they're becoming more common, but if you work in the right place, they certainly seem like they're becoming more common, for sure. This is sort of what a VAD looks like. There's 3 parts to it. There's what's implanted in the heart. There's a energy source, batteries on the outside, and a pump that keeps it all working. HeartMate happens to be one brand, one model that's fairly common. The thing with VADs are, the heart no longer beats per se. I mean, the dysfunctional part is still beating. There will still be an EKG if you do an EKG. But in terms of blood flow, these pumps are continuous. They're not a lub-dub pump. It just moves blood continuously. And you can see here, the pump is connected directly to the lungs, where it's taking the vast amount of the blood out of the lungs. There is still some flow through the heart, but the vast majority of the cardiac output is coming directly through the pump from the pulmonary vasculature. It runs through the tubes, excuse me, outside of the heart, and again, that's continuous. And then it's pumped right into, not even the left ventricle, it's pumped right to the aorta so that it's going out to the systemic circulation. And it's continuous. So if you go to do a blood pressure on a patient with a VAD, you only get a systolic reading. You don't get a lower number because you're essentially not, it's just a continuous pressure. There's no resting period where with that pump, you know, squeeze, wait, squeeze, wait. That's what creates the systolic and the diastolic. It's just continuous blood flow. So you literally need a Doppler to check a patient's blood pressure when they've got a VAD in place. And again, so continuous pump and battery sources. The batteries are highly effective. They getting smaller all the time, but needless to say, power outages are a big deal for these people. And they're far more common in the community than I think we all realize. And so when you have a storm like we had this summer, it's a big deal for patients. They've always got to have backups. They've always got to have something at the ready. They need to have a plan to go somewhere to get power. I mean, even if it's coming into the hospital to plug in and to recharge, as the case may be.
Hey, Carolyn, I have a question.
Sure.
Does the blood leave the ventricle and then go through the device and then go up to the aorta, or it comes from the aorta and goes into the ventricle?
No, it comes out of the pulmonary vasculature,
I think that's
kind
the
of
aorta.
never leaves the heart, never enters the heart. I mean, it goes right through the pump and then usually the implant is right before the aorta, so that it literally avoids the majority of the left ventricle. It goes right to the aorta. Does that make sense, James?
Yeah, I just took a photo of something on image on the internet. It shows it going the opposite direction, coming out of the ventricle and then going up to the aorta being up top. And I'll just share it with everyone.
Okay. Yeah. Again, it often depends on, again, the left ventricle is the major pump, but is the biggest pump of the heart. But my understanding was it avoided like all chambers of the heart. You're saying it comes right from the ventricle back to the aorta. All right, I'll look at that. Thank you. These patients need to be anticoagulated. We have clearly altered the blood flow. We're creating points of turbulence, so they need to be anticoagulated. And while, as I said, many patients start this therapy knowing that they are in destination therapy. They're not waiting or hoping for a heart transplant. But for the patients who are hoping and waiting for a transplant, my experience is that they're quite thankful for the VAD that helps them while they're waiting, but they're still constantly anxious and on edge because they're still waiting for the transplant. They're still waiting to hear whether they're going to get an organ or not. So there's really quite deep-seated anxiety and psychosocial concerns for these patients as well. We've talked about myocardial infarction. I put up some of our review lectures from last spring. We know the coronary arteries are bringing oxygenated blood to the myocardium. We need to keep that muscle working. When those arteries get blocked, we end up with ischemia, lack of oxygen getting to the muscle. And then infarction is necrosis or muscle death. When the myocardial oxygen demands greater than supply, you have ischemia. The supply has to meet the demand. That's when you get pain, you get myocardial dysfunction, shortness of breath, all of those things. And that can often be seen on EKG in terms of changes on the 12-lead EKG. Ischemia looks like on the EKG inverted T waves. And next week when we go through the EKG, that'll make more sense. Time is muscle, just like time is brain, time is muscle. This is an emergency. This is why these patients, when they come in, the clock starts ticking. And we need to assess and we need to treat promptly. It's one of those publicly reported quality measures. Getting them up to the cath lab for angioplasty, getting them on TPA to try to break down the blood clots, really important. What's an aneurysm? Jack, what's an aneurysm? I only know because he explained it to me so beautifully last week.
I explained it as like a blood vessel that has like a little side pocket that's pooling blood and it's at risk for rupturing. The analogy I used was like a boil on someone's. I always think of the boil from Fairly Odd Parents, where like the kid just has a big boil on his face, but it's essentially a vessel that has a boil where blood pools into it, and it's thinner and at risk for rupturing.
So yeah, I think of a boil filled with pus, but you're thinking of a boil as filled with blood. But it's definitely a weakening of the arterial wall that's at greater risk for rupturing. And you know, you don't want blood leaking out of your arteries. They're supposed to stay in the arteries. That's definitely what an artery is for. It's not uncommon. Aneurysms can be found in arteries all over the body. We're looking at aortic aneurysms right now. Aortic aneurysms occur in men more commonly than women. Again, this is a risk of aging. They're more common in folks over the age of 55. The majority of them occur below the renal arteries. They are far more serious when they occur near or around the renal arteries, because again, we don't want to risk blood flow to the kidneys. Kidneys do not like that. And they can occur in the thoracic area also, a thoracic aneurysm, which has a slightly different pain and symptom profile as well. So again, here's your big old aorta coming out of the heart, heading down. There are your renal arteries coming off right and left, and then it bifurcates to your femoral arteries. And this is an aortic abdominal artery, and you can see how much wider the aorta looks here. This one is coming up towards the aortic. This is a fairly significant one for sure, large to say the very least. Our aneurysms don't always occur one at a time. Patients who have one may have others. So again, ultrasound and CAT scans are important to really survey the entire area. If an aorta is larger than 3 centimeters in diameter, it's considered to be aneurysmal. And how they grow, how they get bigger is unpredictable. But we know the larger it gets, the greater the risk for rupture. And they, again, depending on the patient, what's going on, they usually at 5 centimeters, they determine them to be more the greatest risk for rupture. So again, increasing with age, men, folks with high blood pressure, greater risk for aneurysms, people with coronary artery disease, there is a certain familial trend to them, high cholesterolemia, and folks with lower extremity peripheral arterial disease. Those are some of the risk factors for aortic aneurysms. People with a history of a previous stroke, smoke, obesity, and different backgrounds have greater risks for aneurysms as well. So when we're talking about thoracic aneurysms, again, these are those up in the chest area, we tend to identify them as either ascending aortic aneurysms or descending aneurysms. And an ascending aneurysm is something that's coming out of the heart up to the aortic arch. So it's that smallish area from the heart up to where those carotid arteries are coming off. These folks have a high incidence of angina. They have changes in their voice, more pronounced hoarseness, depending on how big it is and where it's positioned. If it is causing flow problems through the superior vena cava, that's also a problem. They end up with what they call vena cava syndrome, which means they're going to have decreased venous return, distended neck veins, edema of the face and the arms. These are really signs and symptoms of a real serious problem. And whether it bursts or not, anytime you're getting alteration in that large vessel blood flow, that's a problem. Superior vena cava syndrome is sort of an acute emergency. Again, usually because it's a sign of something even worse happening, but it's certainly a concern. Abdominal aortic aneurysms, in the right sized people, you can literally palpate a pulsatile mass. The aorta is a big artery, but being able to pulsate that mass is not, is one of the things that you are looking for when you're assessing for an abdominal aneurysm. You may hear a bruit when you auscultate in that area. There could be some abdominal distension, some discomfort, but often people with aneurysms, whether it's thoracic or abdominal, will complain of back pain. They can't get comfortable. They tend to be very twitchy in their bed. They're always shifting, trying to get comfortable, but they can't. If there is a bleeding, and because of these aneurysms, they're at risk for embolisms, what they call these blue toe syndromes. They can get mottled feet and toes. They still have palpable pedal pulses, but the feet and the toes get very gray, very blue. So it's really sort of unexpected. You don't expect gray and blue with pulses. So that's usually can be a sign of embolisms within an aortic aneurysm. If an aneurysm does rupture, you're going to have bleeding into that peritoneal space. Depending on how much bleeding, how close it is to different structures, sometimes the pressure of the other structures can help decrease the amount of bleeding. But if you don't get that tamponade action, you end up having massive internal hemorrhage with death. Again, rupture, patients complain of back pain. They may have ecchymosis in the flank area. Again, that's a sign of retroperitoneal bleeding, where the bleeding is internal, but you can literally see the ecchymotic areas, the darkening areas of the blood pooling even through the body. Signs of shock, an acute abdomen. Remember when we talked about an acute abdomen, it's not just firm, it's hard. It's painful, it's tender. All the things that come with massive hemorrhage, low blood pressure, tachycardia, ultimately restlessness, agitation, change in level of consciousness leading to coma. And if it's an acute big rupture, they may not even make it to the hospital. So it's, again, a significant emergency. Ultrasound is some of the best way for an acute quick diagnosis. It shows the blood pooling. We can also look at aortic valve functioning, especially in those ascending aortic aneurysms. And once an aneurysm is diagnosed, monitoring the size is really important. So people need to come in regularly to have that aneurysm checked by some sort of diagnostic imaging test. And again, just because it's growing doesn't mean it's going to keep growing, but once it's over like a 5 centimeter measurement, that's usually considered actionable by the surgeons or the vascular folks, interventional radiologists and all. And like I said, CAT scan, ultrasound is quick, CAT scan is even more definitive. They measure the length as well as the diameter across. You're looking for blood clots as well. And then trying to figure out what's the best way to repair or to mitigate the concerns. And then the location and the severity are what sort of determines the treatment. Location is also very important to determining the treatment, which I think we'll see in a minute. Again, we want to prevent rupturing. The whole point is to treat it before it ruptures, before it even starts leaking. So early diagnosis is important. Assessing it is important. Figuring out, the more symptoms, things like that, we may want to, intervene earlier versus later. In the olden days, these abdominal aortic repairs, these folks were sliced stem to stern, sternum down to the pubis, and it was a long hospitalization along with significant rehab. More and more of these are being done with minimally accessed procedures now. And what they do is a synthetic graft is put in to help strengthen the aortic walls. It can be put in around the aorta, within the aorta, and it just acts as a protective strengthening of the aortic walls. So this is, again, an open procedure where they open the abdomen, they literally open the artery. You can see it's clamped above and below. They open it up, they suture in a graft, and then they close up the area of the aorta around the graft and then release the clamps. This is a big deal. They need to act relatively quickly because, again, if it's below the renal artery, so the blood's going to flow into the renal arteries, but if this was above the renal arteries, you can't really clamp that off for a prolonged period. You got to worry about blood flow to the kidneys. We know they don't do well with decreased blood flow. You run the risk of short-term acute kidney injury, long-term chronic kidney disease. Whether it's an open procedure or a minimally accessed procedure, you're always assessing your peripheral pulses to make sure blood flow is continuing to get down where it needs to get. Neurological status of those limbs as well. So as Linda said, you're going to mark those pulses so you don't spend a lot of time looking for them every however often you go in to check on them. Neurological, can they move them? Do they feel you touching them? Do they have any pain, burning, tingling? All of those assessments in those areas. What's the skin look like? And again, your assessment pre-procedure really does help determine what you're looking for post-procedure. And then again, you want to make sure that graft remains intact and that you don't have any leakage or bleeding or things like that. Again, any sort of cardiac compromise can potentially lead to diaphoresis, paleness, and weakness. So again, those are all of our symptoms that we're looking for. Tachycardia, an effort to support cardiac output. Hypotension could be a sign of bleeding, volume loss, blood loss. And again, folks have just had a surgical procedure. They're probably going to have pain, but we're going to be looking for back pain, groin pain. You have to differentiate between suture pain and other discomforts. Certainly level of consciousness is a hint in terms of blood flow. And again, you're still assessing for a pulsating mass to make sure there's no problems above or below the graft site. Urine output in terms of a measurement of kidney function, risk of infection, so we're always trying to prevent that. And again, peripheral perfusion, pulses, neuro sensations, movement, things like that. You know, I was on a surgical floor yesterday, and there was a gentleman who had a long history of Crohn's disease. Then he was diagnosed with colorectal cancer, has an ileostomy, and he's had through his life had many abdominal surgeries. And does anybody remember what the risk of abdominal surgery, particularly repeated abdominal surgeries, are?
Peritonitis?
Yeah, that's an acute risk, but sort of long term. What happens when you go in and you're moving these organs all around and rearranging them and then putting them back, closing them up, and things like that? What develops? These are why people with repeat abdominal surgeries are at risk for bowel obstructions. I heard
Adhesions?
polyps. No, what was that?
Adhesions?
Adhesions, exactly. So these adhesions are almost sort of abdominal scar tissue. But and so we know scar tissue as it forms, you know, it's not as stretchy, it's not, you know, as pliable. So the scar tissue forms and it sort of pulls the bowel in one direction. Then another scar pulls over here and it pulls it in this direction. And if it gets pulled enough, now all of a sudden the bowel gets twisted, you end up with a bowel obstruction. So this gentleman has had many bowel obstructions in his life. So he comes in again with another bowel obstruction. This was a month ago. He goes for his exploratory laparotomy where they lyse his adhesions. Lysis of adhesions is the surgical term for it. Comes back to the floor, and yeah, you know, it's getting a little bit better. Okay, pain's not as bad. He's progressing. He's doing some clear liquids. He's on full liquids. Okay, he's doing some stuff. Now the pain is back, and he's got some problems, and now he's got a fistula, and so he's draining green stuff that's not supposed to be. This is why I'm not a surgical nurse. He's got green stuff draining out of this fistula that's not supposed to be draining. He's developed 2 abscesses, and he's got drains in both of those abscesses where, again, fluid's draining out of those. He's got his ileostomy that's putting out stool. I must have said a prayer every hour saying, "Oh Lord, take me back to medicine, please." But So I looked over his chart, and what's one of the most important things in a post-surgical patient? If you want to screw up healing, besides infection, if you want to really put a barrier to healing in front of that patient, what could you do for that patient? And now I'm being negative here. What do you really need for good healing? That's a way to ask it in a more positive way. Any
Right.
wound, what do you need for good healing?
Albumin?
Protein and albumin. Yes, that's right, Jean. You're absolutely right. If you don't have a good protein albumin, you're never going to get good healing. What else?
A balanced diet.
What's the balanced diet by you?
Skin healing with the protein.
Okay,
Vitamins and minerals.
good.
And fluid. They should drink a lot.
Yep. Still missing that one thing. Really? Any population we know, any diagnosis we know that has a huge problem with healing wounds?
Diabetes.
Yeah,
Diabetic.
yeah. And so what happens with poorly controlled blood sugars?
Peripheral damage, nerve damage.
Do elevated blood sugars get you good wound healing?
No.
So this guy, for the last 3 weeks, hasn't had a blood sugar below 300. Is it, I mean, again, I'm not that bright, but it does not seem like rocket science as to why none of this crap is healing for the, I mean, I know he's complex, and maybe if his blood sugars were 150 every day, which is frankly not that great, but better than 350, right? Maybe if he was 150, he wouldn't be much different than he is today. But what? How did they leave that man for 3 weeks with blood sugars in the 300s? How did that happen? I don't know. So luckily, the endocrine team has been on it, working with him for the last week or so, and they really were trying to work him, and he was very resistant. They finally got him a little under control. They put more into his TPN because, of course, he's nothing by mouth, and he's going only TPN. We managed to make him hypoglycemic for the last 2 days. We couldn't get a blood sugar above 90. Some of them in the 50s and the 60s. But so, I mean, I understand this guy is very complex, but these are the sorts of things that, and I know he's a sick guy. I know his abdomen must be a hot mess in there. He's 71 years old. He's had an ileostomy for 19 years. He's had colorectal cancer. I'm not even sure I could add up how many times he's been to the OR and had his abdomen checked, but I cannot imagine his status has been improved any with blood sugars over 300 for 3 weeks. I just can't believe that. So again, risk of infection. You've got to control those blood sugars for all patients, but especially post-procedure patients. Especially post-procedure patients. Then we have dissections. And again, any vessel can have a dissection as well as an aneurysm. They sometimes, this is the old phraseology, a dissecting aneurysm. It's not an aneurysm. But what happens with a dissection is the layers of the aortic wall or the arterial wall begin to separate, and blood starts flowing into this false, what becomes a chamber, if you will. So again, you're losing blood volume because it's getting stuck in this area. It is still having pressure applied to it, so that further usually makes the dissection bigger, just splitting those tissues even wider. This also, they call it a false lumen. It weakens the wall of the artery. And so again, this becomes equally as critical as an aneurysm as well. And again, the location of a dissection, it can be significant. So here's an upper, a thoracic dissection. And again, you can see how big it's gotten in the blood that's been pooled in there. It's a weakening of the wall. It happens particularly in folks with chronic hypertension. Blood gets trapped in that dissection. It further pushes through, making the dissection even bigger, putting additional pressure on that damaged area. And again, depending on where it is, where this is happening, if this was down near those renal artery, you would have impeded the flow to the kidneys. If it was higher up on the arch, you impede blood flow up to the carotids. So again, aortic dissection can be life-threatening and also needs to be treated as well. And even lower than here, you get a dissection going to the femorals, and again, now you're not getting blood flow down to the lower extremity, which is certainly a problem. They call a type A dissection as something that starts in the ascending aorta. So it's between the heart and the arch. A type B dissection is the descending aorta, after the arch, down towards the renal arteries and the femoral arteries. I'm not saying that one is more serious or less serious than the other. They're both quite serious. Again, severe sudden pain in the chest, interscapula going down the spine. It's sharp. This isn't antsy or restless pain. This is sharp, hard pain. Sometimes they think it's like MI, but you need to look for other neurologic problems, other respiratory problems. If it's up near the aortic arch, you need to check your carotids and look for neurological presentation as well. And again, dissection is obviously potentially a critical emergency. Got to manage blood pressure for these patients. We don't, because every time that heart beats, you're further pushing blood and furthering the dissection. So managing blood pressure can certainly help provide some short-term support for an aortic dissection. What can happen with aortic dissection is a cardiac tamponade. Again, if the blood ends up in the pericardium, preventing the full expansion of the heart, sort of creating a smaller sac for the heart to do its work in. Hypotension, narrowed pulse pressures, distended neck veins. and pulsus paradoxus. Even this is so hard. It's one of those sort of good news, bad news sort of thing. It's sort of rare, so you don't get a lot of chance to listen and practice for it. But this is when a patient takes a breath, when they inspire, pulses actually get weaker. So if you feel a fluctuating pulse, meaning it's strong, then it's weak, see if it's timed to inspiration. You may have found yourself a pulsus paradoxus. Again, we know pulse pressure is the difference between the systolic and the diastolic pressure. So in this case, in a patient whose blood pressure is 120/80, their pulse pressure is 40. If that number is on a downward trend, you worry about decreasing stroke volume, hypovolemia, decreased cardiac output, and it could be related to a cardiac tamponade. So again, managing blood pressure, beta blockers. Esmolol is one of the classic blood pressure beta blockers used with aortic dissection. It's usually given intravenously on a continuous basis. We can also use calcium channel blockers, nitroprusside, also known as nipride, ACE inhibitors. Morphine not only decreases blood pressure, vasodilates, also helps manage pain. Endovascular repair, again, that's a minimally invasive. This is, these are used, an endovascular dissection is used for descending aortic dissections, and it's done through the groin. Again, where you're putting a graft all the way, threading a graft all the way up to wherever the dissection is and clipping it in internally. It can also be treated surgically, where they essentially, somewhat similarly to what they do for the previous concern. They can insert a graft surgically as well. With surgical treatment, women don't do really well with surgical treatment of aortic dissection. They do much better with an endovascular procedure. So they try to do that. But again, so again, the less invasive has shown really wonderful outcomes with much shorter lengths of stay, much fewer complications. But it's often which one is better for the patient or able to be done for the patient often is determined by where the dissection is on the aorta. All right, that was it for today's lecture. But I've got a case study I'd like to do. So why don't you guys take 14 minutes, come back at 12:45. We'll do the case study, and then I'll get you out of Dodge, okay? Any questions so far? James, did you send me that thing on the LVAD also, or did you just send it to your
It's in
friend?
the chat, Caroline. If you just click on it, it'll appear in the chat.
Okay, cool, thank you.
Yep.
I'll see you guys back at 12:45, okay?
Okay.
Thank
Gonna
you.
pause, record. Thank you. And so we've got a 50-year-old gal who has a genetic autoimmune deficiency, and she has had recurrent infective endocarditis in the past. Recent episodes were Staph aureus infections of the mitral valve. The most recent was 16 months ago. And Streptococcus viridans infection of the aortic valve 1 month ago. Her echocardiogram from the last hospitalization showed moderate aortic stenosis, moderate aortic insufficiency, chronic valvular vegetations, and moderate left atrial enlargement. 2 years ago, she had 18 months of TPN for malnutrition caused by idiopathic relentless nausea and vomiting. She has a history of coronary artery disease. And 2 years ago, she had an acute anterior wall myocardial infarction. She also has a history of chronic joint pain. She's been home for a week, and now she's readmitted to the floor with endocarditis, nausea, vomiting, renal failure. She's been vomiting and retching constantly. She has chills, fever, fatigue, joint pain, and headache. You're doing her admission assessment, and you note that she wears glasses, has a dental bridge. She has IV what? Is that my feedback? Okay. She has IV access with a double lumen PICC line. And here's other results and other orders. So fair to say, a lot of information there. A lot of it, well, let's get to the questions. Let's review all the information. So her admission orders are for blood cultures. And this is typical of blood culture order. They want ×2 from 2 different sources. And you send, there's usually 2 bottles, an aerobic and an anaerobic bottle. They grow in different mediums. And just as an aside, you can, if you prep the skin properly, as you would for a blood culture, when you're inserting an IV, you can draw blood cultures just like you can draw blood for lab samples when you're inserting an IV. But you really should not draw blood cultures from an existing IV line, whether it's a peripheral line or even a PICC line. If you draw cultures off a PICC line, usually what you're checking is the PICC line infected? It's not always indicative that there's a blood infection. So when you're drawing blood cultures, you need 2 separate blood draw points, you know, like right arm, left arm is best. They don't, you know, even not necessarily the same arm is best practice. They need a metabolic profile, a CBC. They want to start her on TPN at 85 milliliters an hour. They're going to start penicillin G, 2 million units IV piggyback every 4 hours, vancomycin, renal dosing, IV piggyback every 12 hours, Lasix, 80 milligrams a day by mouth, amlodipine, Norvasc, 5 milligrams every day by mouth, potassium chloride, 40 milliequivalents each day by mouth, metoprolol, 25 milligrams, ondansetron, Zofran, 4 milligrams IV every 4 to 6 hours for nausea and vomiting, a TEE as soon as possible. And then your admission assessment found blood pressure 152 over 48 lying, 100 over 40 sitting. Heart rate of 116. Does anybody know what's missing there in that 2 lines?
Whether or not it's regular or irregular.
That's a good one, Jack. You know, that's one of my pet peeves, but it doesn't tell me what position that heart rate was in. You should take a heart rate when you take the blood pressures, again, both sitting and lying. Anyhow, a respiratory rate of 22, temp 100.2. Again, how that was taken should be there. Oriented times 3, but drowsy. She has a grade 2 out of 6, because murmurs are graded on a scale of 1 to 6. So this is a 2 out of 6 holosystolic murmur and a grade 3 out of 6 diastolic murmur on auscultation. When you documenting, when you hear a murmur, you also usually say where it was best heard. So, you know, intercostal space 2, 3, 4, 5, mid-clavicular line, sternal border, with the patient sitting up. That's helpful also, again, for folks who want to try to recreate a good listening experience. Lungs clear bilaterally, abdomen soft, with left upper quadrant tenderness. Multiple petechiae of the skin in the arms, legs, and chest, splinter hemorrhages under the fingernails, and hematuria noted in urine voiding. All right, so what's the significance of the orthostatic hypotension and tachycardia? What does that mean?
It means that the blood volume is escaping from somewhere, so it's compensating for it.
There's a decreased cardiac output.
Okay, so we've got decreased blood volume, decreased cardiac output. Another word for that's hypovolemia. In her case, what do you think the hypovolemia is related to?
Aortic.
Hold that thought first. Anything else in her presenting history causing hypovolemia?
She was nauseating, vomiting a lot.
Yeah, I think in her case, that's probably the leading cause. Might remain to be seen, but I think that that's probably in her case what this is about. How about the abdominal tenderness, hematuria, joint pain, and petechiae? What did we say one of the risks of vegetation on the valves, which is endocarditis? She also has her last echo showed what? What did her last echo show?
Moderate to atrial enlargement, left atrial enlargement.
Yeah.
So like clots and embolization maybe?
Exactly. Very good. So again, we've got, what do you think her abdominal tenderness was where?
Left upper quadrant.
Right. What sits in the left upper quadrant? What organ's up there?
Tail end of the liver, spleen.
More about the spleen, yep. So as Linda said, we know with valve problems and her insufficiency and all that you worry about emboli, when we have emboli moving throughout, again, we talk so much about stroke, we talk so much about myocardial infarction, but these embolisms can get caught essentially anywhere in the blood flow. So other organ infarctions are definitely possible. So you worry about the spleen, an emboli in the spleen can be causing that pain. How about clotting in the kidneys, causing dysfunction there, causing hematuria? Could cause decreased urinary output if the blood is blocked. And how about all those petechiae? What's causing those petechiae, do you think?
Microembolization.
There you go. Good. Now again, she could also end up with a stroke, could also end up with myocardial infarction, but right now she's got even more organs potentially involved. And the splinter hemorrhages on her nails. Those are
They're
all
like the reddish streaks, reddish brown.
Yeah.
Linear.
And those
they occur with an infectious endocarditis.
exactly. So if you were going to listen for her aortic valve murmur, where's the best place to listen to your aortic valve?
Second intercostal space, right sternal border.
There you go. Very good. You remember your ape to man. So you're caring for JF, the day's progressing. What other signs and symptoms of problems with these emboli are you concerned about? What are you watching for? I sort of gave it away.
I don't see it there, but maybe your platelets.
We certainly know that if platelets get involved in all this blood clotting, there's going to be fewer around, that's for sure. But with these emboli traveling around,
Do you
what
think
others?
PIC? Is that what you're shooting for?
No,
Okay.
just traveling emboli. What kind of trouble can they get into? What happens if one travels up to her brain? What's that going to look like? What do you think?
Stroke.
Yep. So how do you assess, how are you assessing a patient for a stroke? What's
Facial
that
droop.
look like?
If they can hold their arms up, they can smile, symmetry.
Changes in level of consciousness. What if they get stuck in some of the smaller peripheral vasculature? What's that look like?
Pain, warmth, redness. Decreased circulation.
and is decreased circulation, pain and warmth and redness?
No, that will be on the site of the clot would be cold and decreased circulation. But like, for instance, when you're assessing a DVT, they would have the warmth.
Yep. Remember, this is mostly arterial circulation. So it's going to be pale, pulseless, tingling, numbness. You're looking for signs for decreased arterial circulation in most cases. And if it gets into the bowel, arterial circulation, abdominal pain, cramping. She's already got the nausea and vomiting, could potentially be diarrhea as well early on. And if it progresses, then it's decreased bowel sounds and decreased movements. So how is her endocarditis, which given her history seems readily obvious, but what are we looking for in terms of making a definitive diagnosis? What test did you send off that's going to give you your biggest hint?
Blood culture?
Blood cultures. So we're going to check to see, that'll tell us if they're positive and help us determine what the best antibiotic is.
Echocardiogram and EKG.
Echocardiogram will show us if there's vegetation. What's the murmurs also telling us? The murmurs say that the valves are not either closing or opening competently. There's turbulent blood flow. And so those valves are not working 100%. And that's, again, the ultrasound or the TEE will give us a good shot of that. The fever as a sign of infection also. All right, so let's see, what's back? Our lab tests. Sodium, potassium, chloride, BUN, creatinine. Anything scream at us there?
The BU runs really high.
BUN certainly.
So is the creatinine.
Creatinine also. Is there anything, what else is a little out of whack, not a little, but anything else out of whack there? How are you liking the H&H?
Hematocrit's low.
Mm-hmm. And is there anything surprisingly normal in that list?
Her white blood cells are fine.
Yeah, that sort of surprises me, to be honest with you. Makes me wonder. Why do you think her H&H are low? Let's take a moment, just go back to the history.
Renal failure.
Yep. So the only thing I will say is, to me, the fact that her, she certainly has a high creatinine, BUN, indicative of renal failure. It says she's being admitted to the floor. It doesn't really say she has a history of renal failure. I mean, she's certainly given her history in terms of nausea and vomiting, which, she may have been hypovolemic, which can impact the kidneys. She has a history of an MI. Again, that's usually not good for the kidneys, things like that. The way they say it here, she's been admitted to the floor for endocarditis and renal failure. It doesn't say whether it's chronic or acute. And the anemia that comes with renal failure is really kind of considered an anemia of chronic disease. It doesn't usually become an acute anemia with acute kidney injury unless acute kidney injury goes on a prolonged basis. It's really much more of a standing kidney dysfunction. Do you understand what I mean by that? Like if I come in with acute renal insufficiency and my kidney function was normal last week, but this week I had a hypotensive event and my kidneys were impacted, I'm not all of a sudden going to become anemic because of that. It takes a little while to kill off the epigen working part of the kidneys. So that's a little surprising, but right now that's probably one of the best reasons for her anemia, because there's no real reason for blood loss or anything like that. So now we have a new order for fasting blood glucose levels every day. What do we think of that order? Reasonable or problematic? And let's go back to her orders just so we can review those.
You need blood sugar with TPN.
But it's written as a fasting blood sugar. Is she ever truly fasting?
No.
Not.
TPN, I mean, there are people who what they call cycle TPN. They'll, especially if they're on long term, they'll run it at night so that they can have more flexibility during the day, sort of thing. But it essentially runs continuously, so you're never truly fasting. You're right, Ho, we need to order blood sugars because of such the high and so why do we worry about blood sugars with TPN?
It has dextrose in it.
What kind of dextrose, Jack? And can we be a little more specific? I mean, you run D5W, D5 normal saline all the time in patients. That big a deal? Is that the kind of dextrose in TPN?
Is it 10?
They had the guy yesterday down to 12%, which I think was the lowest dextrose concentration I've seen in TPN in a long time. It's often 20, 25%, to be honest with you. It's highly concentrated. I'm telling you, TPN and the risk for infection, huge. Oh, it's a bug's delight. That is like nirvana. every little thing they could, the only thing better than TPN is blood. Oof, they love it.
So should the glucose be taken more frequently than once a day then?
They usually, yes, John, if the patient's on TPN around the clock 24 hours, I'm more familiar with it every 6 hours. That's the regime I'm most used to. And if they're being cycled, meaning they do have a period where it's off, the other thing is you can't just shut off that concentration of glucose. It needs to be tapered down. So for instance, the gentleman yesterday was only on it for 16 hours a day, 1/6. So he's at 120 milliliters, then he goes for an hour at 60 milliliters, and then the next hour 30, and then he's off. So it's a 3-hour tapered off. And blood sugar would be checked in an hour after you start the weaning, and then an hour after it's discontinued. So again, we agree that we need to check a blood sugar. It should not be ordered as a fasting, and it should not be ordered as daily. It should be, if it's continuous, it should be around the clock. And as we're going to rehydrate this gal, is there anything that we're concerned about in terms of rehydration, given her overall health history?
Fluid volume overload.
Why is that, Linda? You're correct.
If the TPN is given too quickly, the amount of fluid that's in it can overwhelm the system.
Yeah. And certainly if you add any other
Kidney and heart failure issues.
Right. So what are those signs of heart failure that we're looking for?
Pulmonary edema.
Be a little more specific. You're right.
Maybe
JVD.
shortness of breath.
Shortness of breath.
JVD.
JVD.
Crackles.
Crackles.
Hypertension.
Hypertension.
Changes in level of consciousness.
Very good.
Increased body weight.
Long term, yep. Or over days, yep.
Bounding pulses.
Mm-hmm. Anything with heart sounds?
Worsening murmurs.
Maybe. But what's a classic heart sound that comes with heart failure? Kentucky, Kentucky, Kentucky.
S3.
S3 and sometimes S4. Yep. And again, with her renal failure, she's a risk also. Okay. So she's getting ready to go home, probably with her TPN and her IV antibiotics. You're working with her home care agency. What sort of information, as you're planning for discharge with this gal, are you, what sort of, as you're making plans for her to go home, what do you need to know about her home environment to make sure she makes a safe transition?
her support system, and if like somebody is nearby that can help her if she needs it,
Good,
if there's electricity.
good.
She could be going home with the central line, so if she's able to take care of that herself, if she needs visiting nursing to help.
Yep, very good. She's going, it looks like she's going home on TPN and antibiotics. Those have to be delivered one way or another, right? And you know that, and I actually, at this point, I don't remember. I must have known at one point in time, but right now I can't remember. But is anybody taking care of somebody getting TPN at the hospital?
Yeah.
So can you just talk about the process of like the order and getting it and anything special, anything come up in the care of that patient, Jack?
Yeah, well, it's either like Gevity 1.2 or Gevity 1.5, and then they also have Diabetosource.
Oh, no, that's tube feeding. I'm looking at TPN.
Oh, no, never mind then.
TPN's intravenous through a central line.
Right. No experience there.
Yeah. Your day will come, trust me. Anybody else? So my experience with TPN is it's got to be ordered every day. The concentrations may have been the same for this patient for the last week, 2 weeks, month, whatever the hell it might be, but the order has to be written every day. The bag is made up every day, again, because of the risk of infection. And at least a couple of hospitals I've been in, by a certain time, that order needed to be in. And again, when it was written and it had to be transported down to pharmacy and all, it was one thing. It's a little bit easier now because you can beat people and say, use your phone, type your order in, please, soon, now. But if it was late, you just didn't get TPN that day. And then you ended up running some high, patient went without food for a day. It was kind of a problem. So my question is, part of that is because of the cost of TPN. They certainly don't want to make it in advance if the patient doesn't need it. But the other issue is it's such a high risk for infection. It's not the sort of thing you can have sitting around waiting, because the longer it's in existence, if you will, the greater the risk of contamination, even in a closed system to a certain extent. So how does that work at home? Do you actually get a delivery every day? Can you imagine the cost of that, how labor intensive that is? On the other hand, if you get a delivery every couple of days or every week or so, how do they store that? I mean, not everybody has, it's got to be stored in a refrigerator. Not everybody has a refrigerator who can handle, I mean, she's only on 85 milliliters an hour, but over 24 hours, that's still almost 2 liters. Let's say you get a delivery twice a week. Does everybody's refrigerator have room for 2 or 3 or 4 2-liter bottles / bags in it? I mean, you sort of the operations of it become a challenge. So we talked about her support system, and that's both physical support in terms of caring for her line, helping her if she's weak and tired and not able to do for herself. I bet you there's a little emotional support that's necessary also, right? Her home care agency to help monitor her. Does she have a relationship with an existing relationship with an agency? Does she need an agency? I think it's fair she needs an RN, but what about other supports? Would it be helpful for a home health aide or a housekeeper or something like that to come in? How about physical therapy to start some rehabilitation? Does her insurance cover any or all of this? Are there co-pays that can or cannot be handled by the family? These are some and while the bedside nurse may not be dealing with this directly, again, many hospitals have case managers, discharge planners to help facilitate some of this. You're also, you're the ones with the patients at their bedside, often working with the visitors and the family who come in also. So you're often a pretty good source of information and perspective as well. So she's got supportive family who live nearby. They're going to help as caregivers. We need to teach them about endocarditis. They've actually received little education about the disease, the diagnosis in the past. So what are some of the things you want to include in your teaching plan? What do you think they need to know? And especially given not only about endocarditis, but about her discharge plan. What do you think they need to know?
Monitor for signs, symptoms of infection.
Very good. And we've talked about what those are. I'm not going to belabor those again, but that's great. How are they going to prevent infection? What are some of the ways they can prevent reinfection, if you will, or problems?
Like hand hygiene and keeping your site clean and dry.
Excellent. It sounds overly simplistic, but if one of the things I think we've learned in the last 6 to 9 months is some of those really simple rules that we think are incredibly simplistic need to be reiterated surprisingly frequently. And not everybody still doesn't listen to you, right? What does she need to know about endocarditis? How do you simplify what endocarditis is so that a lay person can understand it?
An infection of the heart that affects the valves.
Yeah. And that one of the problems is that there can be little, if you will, I'm not exactly sure what phraseology I would use. I'd have to, like survey the room to see how it's going on. But the infection can break off, and if it travels, it can create blood flow problems in other areas of the body. And that's, explained that that's what was causing her abdominal pain and other issues that she had. How about her ongoing health maintenance? Anything she needs to know about how she keeps herself healthy moving forward? So avoid getting sick and other infections. What does she need to do if she goes to the dentist?
Prophylactic antibiotics.
Prophylactic antibiotics, that's correct. She needs to, communicate with her other healthcare providers. Again, don't take it for granted that everyone has access to everybody's medical record. It's sometimes you need to check to confirm, especially with new clinicians and all. Certainly, any medications she needs to be taught about, why she's taking those medicines, anything she needs to be concerned about. What is a PICC line? Things like that. So you've taught her about oral hygiene. Which statement reflects a need for further education? I will remove my bridge after every meal and clean it thoroughly before replacing it. I will use a water irrigation device to clean my teeth and gums. I will use a soft toothbrush to brush my teeth, or I will rinse my mouth thoroughly with water after brushing my teeth. Which one says you need additional education? And this is a little counterintuitive.
Do you not want to rinse the mouth thoroughly with water after brushing?
I think some might argue you might want to use
Or don't use water irrigation, I guess.
you might want to use a mouthwash or an alcohol-based mouthwash to really do a little even more antiseptic in the mouth. But there's actually a better answer on that list.
I would say B, not to use water irrigation because it's like forcefully dislodging all the bacteria.
Yeah, folks with a history of endocarditis should not use either floss or a water irrigation. That actually promotes bacteremia in those patients. So, at least I think of that as being sort of not only, floss, certainly basic mouth teeth hygiene. And if you use a water irrigation device, people who do use it thinks it's the best, that, it really does a great job between the teeth and all. But for folks with endocarditis, it actually seems to promote bacteremia and recurrence of endocarditis.
What is a bridge?
A bridge is, instead of having a full denture plate, Jonathan, if they're just missing a tooth or two, or more than one tooth, but 2 or 3 teeth, they used to get a removable false teeth for just those few that were missing. So that a bridge, meaning a bridge between the native teeth to fill in the space. I think they're less common nowadays because of dental implants. And they're not as big as full denture plates. They used to be much more common. That help?
Got it. Thank you.
Okay, so the discharge planner facilitates her transition to home. During the initial home visit, the home health nurse evaluates her IV site for implementation of her IV therapy. The nurse interviews the family to determine their willingness to be caregivers and their level of understanding, and lists the patient's and family's assistance to identify goals. So the home health nurse also writes short and long-term goals for the patient and her family. Can you think of any short-term and long-term goals that would be appropriate For her, let's focus on short term first. Again, very, kind of straightforward, and in retrospect, they might seem obvious, but
Appropriately administering the TPN and the antibiotics using proper technique.
So technique. How about just keeping the PICC line patent and working? Having the supplies. I mean, those sort of delivery things can be the things that make you absolutely crazy and problematic. How about long-term? Again, kind of straightforward. And what's our long-term goals for this?
Prevent future infections and prevent recurrence of endocarditis.
Very good. And again, a little bigger picture, given her health history. Maintain her cardiac function. Increase her activities of daily living, right? Keep fluid and electrolyte balances within normal limits. Depending on her continued kidney function and, weight monitoring. We really didn't talk about that, but she should be doing daily weights as much as possible also. So all in all, good news is they get through it and the endocarditis is resolved. Right. So I'm going to post the answers on the site also so you can review that. You guys will get back to me with any questions unless you've got anything now. Anything other? I asked about, if you've ever done some stuff in clinical. Any good stories from clinical this week, last week? Anything that's come up you want to talk about? How do you feel about being back in the hospitals?
It's great.
Mm-hmm.
Kind of remind you
Yeah.
why you came to nursing school to begin with?
Yeah.
Okay. All right. I'll get a, what's that thing called? Blueprint out. We'll have class next week. You'll hunt me down if you need me. You'll take care of yourselves and each other. Anything else I'm forgetting? All right, guys, take care. I'll see you, talk to you next week.
Okay, Caroline.
Sounds good.
Carolyn.
Thank you. Bye.
Thank you, Carolyn.
You're welcome.
Thanks, Carolyn.
Kids.
Bye.
Bye.
Thank you.
Welcome.
Thank you, Carol Ann.
You are welcome.